We have one more excellent talk. We're going to hear from Dr. Lubelski about sort of how advances in non-surgical specialties change our surgical strategy. So, Dan, thanks for being here.
Oh, thanks a lot. So I was asked to talk about the use or how advances in radiation and molecular therapies changes the surgeon's practice. Here are my disclosures. I do research and some consulting for some of the carbon fibers. I'm not really going to be talking about that and some of the other disclosures that are not relevant to the talk. So the objectives are: how does radiation oncology and systemic therapies advances shift the role of surgeons, and what's the evolving, initially was a surgery first approach, and now it's more strategic interventions and collaborative approaches. So traditionally, the way we thought about oncological resection was en bloc, which was associated with high morbidity. There was limited systemic options, and then as the decades progressed, the introduction of SBRT allowed for more selective surgery, better radiation therapy outcomes, and then with targeted therapies, the calculator tools that have been brought up by pretty much everyone on the panel tonight. There's a lot of complementary topics that were discussed tonight, and I think it's important to reinforce those points. So you'll see some of that here as well. And so the current trend is being more selective with our surgeries, multimodal management to enable patients to get off the table faster, get out of the hospital faster, and enjoy a palliation of their symptoms without having the end of their life be surgical recovery. So 65-year-old man presents with a T8 renal cell cancer metastasis. He has progressive gait dysfunction, weakness, urinary retention, minimal comorbidities, and well-controlled disease. Severe cord compression, ESCC3. What's the management? So the old approach was this. You have a renal cell. It's going to be highly vascular. It's radio-resistant to conventional radiotherapy. So you're doing en bloc. And, even in our own series, not too many years ago at Hopkins, this was, a standard approach. With the advances in stereotactic radiotherapy, the advances in tyrosine kinase inhibitors, that has become the standard of care for this lesion. And the surgical implication, the implication of these advances for the surgeon is now your decompression is way more limited. Your construct can be smaller, your morbidity is less, and you have improved local control. The NAMS decision has been brought up. I'm not going to reiterate this too much, but I think just pointing out some things here is important. We always look at the ESCC grade or the Bilski grade, 1A, 1B, 1C, 2, or 3, and the degree of neurological symptoms and the radiation sensitivity of the tumor. So what does that mean? You have different lesions here. You can see 1A, 1B, 1C are varying degrees of dural impingement, but no cord compression, and 2 and 3 are varying degrees of cord compression. In the like was brought up by some of the previous panelists, in the hematological malignancies, doesn't matter what it is, they're all getting conventional radiation. And not only are you getting reduction in epidural disease, but oftentimes even in the lytic tumor, you're seeing consolidation of the bone, and you could avoid any sort of intervention. Sometimes we do end up with interventions in these cases, but often you can avoid it. You have prostate and breast, which are moderately sensitive, especially with SBRT. And the moderately resistant and highly resistant are getting, in our institution, typically 40 to 50 gray in 5 fractions. And you've taken things like renal cell, which was always considered a highly resistant tumor, and you're making it relatively radiosensitive. So what are the advances in radiation? In SBRT, the high dose, the precision of this tool expands the role of separation surgery over gross total resection. Gross total resection is no longer the standard of care, and you even have some kind of old school oncologists, that I'll see once in a while on varying tumor boards, not the ones that we're routinely seeing, who are still looking at that and saying, why are you not taking out more tumor? But we're seeing more and more that is no longer necessary. SBRT is preferred when the tumor is oligometastatic. It's used both for local control and for pain palliation. There's significant data show to improve local control compared to conventional radiation. Particle therapy or heavy ion therapy includes proton and carbon ion. This can be used for chordomas and sarcomas when en bloc resection is high risk, or as an adjuvant modality. It is very important to recognize, though, as you're discussing these options with patients, that both proton and carbon ion therapies cause significant wound healing issues. It's effective at tumor control, but it does cause downstream risks. And there's data coming out of Sloan Kettering, MGH, out of our institution at Hopkins, showing the use of either neoadjuvant, adjuvant radiation in combination, photon, proton, both in chordoma and other primary tumors, as having an increasing role, not necessarily in lieu of surgery, but oftentimes in complement. And there's even early modeling out of our institution and others showing the use of stereotactic proton therapies, which I think is going to see more and more coming down the pipeline. So radiation paradigms and targeted therapies enable us to have more MIS approaches. Dr. Lawrence brought this up to some extent. Sloan Kettering published their paper on short segment constructs. No longer do we necessarily need to do 3 up, 3 down because it's cancer bone. Going 1 up, 1 down with cement augmented screws can oftentimes lead to really great outcomes with minimal failure rates or hardware issues. Tubular surgery, as was brought up by some of the previous panelists, is important as well. You could see perc incisions using a tube. I could even get a small ultrasound probe down the tube to make sure that I've gotten my 2 to 3 millimeter margins before continuing. Some of the previous panelists spoke about the M in the NOMS framework, the mechanical instability. Again, use of kyphoplasty, percutaneous pedicle screws, all as adjuncts to help, especially when used in combination with SBRT and targeted therapies, allow us to not worry about cytoreduction through surgery, but really to focus on using surgery just to deal with the mechanical instability and let the other adjuvant therapies treat the actual oncological disease. And then systemic disease and comorbidities. So we talked about biologic and checkpoint inhibitors. We've spoken extensively about survival nomograms, like Dr. Lawrence, brought up our residents too. Any consults comes in, they're plugging it into the nomogram, they're plugging it into the SOAR calculator, and we're talking about what is the prognosis. The S is just as critical as the other more surgically relevant factors in deciding on who to operate. And prediction modeling already exists extensively in oncology, but now we're just being exposed more to it as surgeons and incorporating it into our paradigm. We have multiple times a week are we talking with our oncologists and radiation oncologists to make these decisions. But exactly like all the previous panelists said, oftentimes it's the middle of the night, or it's, you're trying to get someone to surgery the next day and you don't have time for the oncologist to come and have a prognostic conversation. So as a surgeon, being equipped with some of that information, knowing, is this patient on first-line therapy, second-line therapy, third-line therapy, that matters in the prognosis. And then what does the SORG or other nomograms predict is important. So how do we fit in path biomarkers and genetics into this whole paradigm? So we look back in kind of the history of oncological treatment, 3000 BC to pretty much the end of the 19th century. We're talking about surgical treatment. Then we have the development of radiotherapy in the 1900s, chemotherapy in the mid-1900s, and then we have TKIs, monoclonal antibodies, and checkpoint inhibitors in modern day therapies. What are the cancer markers that the surgeon needs to know? For lung, you're looking at EGFR, breast, ERPR, HER2 mutations. These all will have implications both in prognosis and in what therapies are available. Why does that matter? It matters because if you have an EGFR negative non-small cell lung CA coming in a 78-year-old that's frail, doing the 1 up, 1 down cement augmented screw if they need surgery is relevant because they're oftentimes not going to live a long life. In contrast, you have the follicular thyroid cancer metastasis, or you have the prostate cancer metastasis in someone who has relatively well-controlled disease, then you do want to think about the anterior column reconstruction, the better biomechanical stability. One of the questions that was raised earlier is when are we fusing and when are we not fusing? Oftentimes for me, it's the patient that I think is going to live a long life. Just recently I had a woman in her late 70s with a thyroid cancer that had lived 2 years after therapy and developed a degenerative issue between previous constructs that we were able to address. But thinking long term about who are the survivors, who are the ones that are on, first line therapies, molecular therapies that might live longer is very important. So ultimately, checkpoint inhibitors like pembrolizumab are improving spinal metastasis outcomes. The targeted therapies like BRAF inhibitors for melanoma have shown there's significant data showing that when combined with SBRT, it helps improve local control. Here are some of the other markers. What else do I need to know about the molecular markers and the drugs? The more and more that oncologists are using it, the more and more it's important for the surgeon to know. So it's Friday night. You have a patient that comes in with renal cell. You want to take them on Saturday. You're not going to be able to get in touch with the oncologist. You need to know what chemos they're on, what cytotoxic drugs they're on, how it impacts wound healing, and how it'll impact your surgical morbidity. Checkpoint inhibitors likely do not need to be stopped, but you need to check some other things. Angiogenesis inhibitors, things like Avastin or cabozantinib, the TKI used in renal cell carcinoma as the first-line therapy, is incredibly complicating for wound healing. It's incredibly complicating for blood loss. That's a type of therapy that you need to be thinking like a warfarin or a Xarelto patient that should impact your surgical management. So what are the take-home points? SBRT and molecular therapies reduce the need for radical resection. Surgery remains critical in combination with these things, especially for instability and high-grade epidural spinal cord compression. But ultimately, collaboration with ONC, MedOnc, RadOnc is key, having frequent discussions in order to drive these more targeted and personalized approaches. I did have one study for discussion. This was everyone kind of spoke about some of their surgical cases. I thought this would be interesting to kind of present the alternative. This was a 65-year-old man that was called from an outside hospital with renal cell. He's on cabozantinib. He's already gotten conventional radiation, not SBRT, about 2 months ago because of the multifocal disease. And then within 2 months, he has tumor progression, despite being on the TKI and getting conventional therapy. And he's having progressive lower extremity weakness. They call me about a week into this weakness. It's probably around an Asia B or C. It's quite severe, but there is some flicker of movement. My initial inclination in this particular case was he still has some function. 6 months ago, he was a normal functioning person. He has well-controlled disease otherwise. Transfer him over, and I want to operate. I want to give him a chance. But then you start talking to the oncologist and the radiation oncologist and understanding that sometimes, despite the advances, understanding what's available and what the implications are is important as well. So in the setting of someone that's already gotten conventional radiation within 2 months, a lot of institutions will not do more adjuvant therapy, will not necessarily do SBRT. At our institution, sometimes we will, but oftentimes 6 months is the kind of window before you're going to be doing salvage SBRT. What else? Someone that's failed and progressed through cabometics in such a short time frame, there's data that shows that there's only about a 10 or 15% chance that second line therapy after TKI and conventional radiation, there's only about 10 to 15% chance that there is going to be any sort of improvement in tumor burden. So now you take this person that's a week or 10 days that has progressive disease burden that's failed through within 2 months. They're now looking to do second line therapy. They've already started talking about, unfortunately, palliative. In this case, putting this person through, a salvage surgery that's going to lead to likely wound healing issues will have minimal chance of improving neurological function in someone that has limited chance of that second line agent working. One really needs to call into question whether surgery is prudent in this case. In this case, discussion with the family, they elected not to proceed with surgery, which, sometimes is the case. And so I think having those, really thorough discussions with ONC and RadOnc in these instances can certainly influence the surgeon and should. Happy to hear what any of the other panelists would have done in this case or on anything else. Thank you.
Awesome case, Dan. I'll open it up to the panel. So really poor prognosis, and you're seeing sort of the writing on the wall with this very aggressive disease. And yet the patient has this very dorsally based, you know, not so extensive tumor mass. So what would the panel do?
I had a question. Was there a particular reason that patient had a XRT instead of SBRT in the past?
So I think different institutions have different practices. I think oftentimes when the disease burden, so in this case, he had cervical, thoracic, thoracolumbar, lumbar, and sacral disease. And so they just kind of gave him conformal therapy uh, kind of to all those sites. Sometimes what we'll do, at least at Hopkins, is treat some of the more extensive or the areas with more severe disease burden with SBRT and maybe treat the other areas differently. In this case, at this hospital, that was the approach they took.
I mean, I think, you touched upon the sort of the crux of it is the discussion with the radiation oncologist and oncologist, and that's, what I do. And I think, from my standpoint, I'd be asking the radiation oncologist if this patient could be a candidate for SBRT postoperatively. I think that if that's the case, because they obviously haven't failed SBRT, and even though the TKI medication they have failed, there may be some room for treatment in that realm. So I would kind of do what you did and feel out the radiation oncologist to see if that's an option. And then if it turns out not to be, then I think um, I would probably shy away from surgery as well. But if I thought that we could get them SBRT and it would have some effect, then a resection, I think, of that dorsal mass might be helpful.
I think as a surgeon, I think the toughest scenario is always not operating, right? I think operating is what we were trained to do, what we like doing, and I think that it's for us, it's an easy thing to do. But I also do think that the cases that I regret the most are patients like this, where I thought that, you know what, let's give the patient a chance. And of course, they either die, they don't even make it out of the hospital, or they don't even make it to your first or second postoperative appointment because you get a death notification. So I do think that, like I said, I think that everything, all the other panels, what they're true, which is you kind of want to take a step back and kind of understand, talk with your oncologist, talk with your radiation oncologist, see like, what does it really mean if you're offering the guy surgery to quote unquote give him a chance?
Yeah, I think I would agree. And I think the case as you presented it also just highlights the fact that you have just this tremendous knowledge base that you bring to your decision making to make such a mature decision. And it just shows how I think the improving knowledge base of the surgeon and understanding more about radiotherapy and more about medicines to treat disease like renal cell carcinoma just gives you that knowledge base to really advise the patient so intelligently, even if it's a decision to not pursue surgery. It's the humanitarian thing to do, the mature thing to do. So I just want to sort of say kudos to you for your treatment of that person, because you're doing the right thing that doesn't expose them to something that may not prolong or improve their life, which is of course the most fundamental thing we do.
And thank you. And I will say on that last point, yeah, you look at this image, and the family was the one that initially got connected to me, and they were told it was unresectable, which wasn't really. It was just their understanding. We look at it; it's a dorsal tumor. It looks like it's a chip shot operation. You get it out, you get them decompressed exactly like Dr. Safie said. But I'll tell you this: when I did speak to the family, to Dr. Lawrence's point. It was interesting. I was actually quite shocked that they were grateful. They were grateful that they knew that this decision, this approach wasn't happening because they didn't, explore everything and try everything. They knew that everything was being, they were doing everything the right way. They were pursuing everything correctly. It wasn't that they were just not doing something because they were in the wrong institution or the wrong place, but that it was a thoughtful approach and that provided actually some amount of comfort for the family. And you see that, that happens with, this patient population probably more than anyone else.